So most people have heard about the bad side effects that can be caused by cancer therapies like chemotherapy and radiation. And there's no question that some people can have a lot of bad side effects with these treatments. But the good news is we're becoming better and better at controlling or preventing these side effects. So now many patients can have a high quality of life because toxicity is at an acceptable level with good control of their cancer, with improvement of cancer symptoms and prolongation of life expectancy. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book called A Short Primer on Why Cancer Still Sucks, intended for patients, and it can be purchased online through Amazon Books. So this is the 10th out of 16 planned videos in which I will be presenting some of my views on different topics of cancer. And for further details, you can see my book. Importantly, if you have any personal medical issues, you should consult your healthcare advisors. Cancers develop because of mutations and other things that make them quite abnormal. And cancer therapies are designed to attack these vulnerabilities, the things that make cancer cells different from normal cells, because that's how cancer therapies will kill more cancer cells than normal cells. So cancer therapies are only useful if they do have a greater impact on cancer cells than on normal cells. But even with that, there will be at least some side effects in many patients. When I began my oncology training, we were taught that chemotherapy was preferentially killed cancer cells because they were fast growing or rapidly dividing. But this is very much of an oversimplification. There are several factors in cells that may make them sensitive or resistant to a given chemotherapy drug. And that's why different chemotherapy drugs work differently against different kinds of cancers, and also why they cause different levels of toxicity in different normal cells. So one of the most notorious side effects of chemotherapy is nausea and vomiting. But some chemotherapy drugs cause very little nausea or vomiting, others it's quite bad. So it varies across drugs. And the things that lead to nausea and vomiting with chemotherapy are factors that were designed to protect you from poisons. So if you eat a poison, then you may vomit it up, so it clears it out of the system, so you absorb less. Also, the nausea associated with it makes you avoid that particular product in the future. As with the way that poisons may work, chemotherapy may damage what are called enterochromaffin cells in the gastrointestinal tract. And enterochromaffin cells are very rich in substances called neurotransmitters. And when they're damaged, they will release these neurotransmitters, and they may interact with receptors on local nerves in the gut to cause nausea and vomiting, or they may interact with receptors on what's called the vagus nerve that goes from the gut up to the brain and takes signals from the gut to the brain. Or the neurotransmitters may enter the bloodstream and circulate up to what's called the chemoreceptor trigger zone in the brain, where they can trigger nausea and vomiting. So anti-nausea drugs interact with the receptors for these neurotransmitters to prevent the neurotransmitter from interacting with it to cause nausea and vomiting. And the anti-nausea medications that we have now are much more effective than what we had 20 or 30 years ago. So now a high proportion of patients have minimal or no nausea or vomiting, although a small proportion of patients do still get sick or quite sick with chemotherapy. So the neurotransmitter that goes up highest in the blood first is called serotonin. And the drug ondansetron interacts with the serotonin receptor to prevent the nausea and vomiting caused by serotonin. And so that helps reduce nausea and vomiting within the first 24 hours after chemotherapy. More gradually, a substance called substance P, another neurotransmitter, builds in the blood from damaged enterochromaffin cells. And that can lead to delayed nausea and vomiting over a few days after chemotherapy. But new drugs like aprepitant interact with the receptor for substance P to reduce delayed nausea and vomiting. Other medications can also help, medications like the steroids dexamethasone or prednisone, and they are often given along with antagonists of serotonin and substance P to help better control nausea and vomiting. Also, dopamine antagonists. Dopamine is another neurotransmitter that may contribute, so dopamine antagonists may help. In addition, if patients are taking very toxic drugs that will cause a lot of nausea and vomiting, like cisplatin, then a drug called olanzapine may help. And also some people do find that marijuana or CBD oil can help as well. But there's far less reliance on those now than there was back in the days prior to the availability of serotonin antagonists. The other thing is that if people are getting nausea despite the anti-nausea medications, just reducing the dose of the chemotherapy a bit will help reduce the nausea, often with having minimal impact on the effectiveness of the chemotherapy against the cancer. So that's a common strategy with all toxicities, is just to reduce the chemotherapy dose. The other thing that is important is that not all anti-nausea drugs will work with chemotherapy because it depends on what the mechanism is. For example, Gravol is a histamine antagonist that works with motion sickness, but it has minimal impact on chemotherapy-induced nausea and vomiting because histamine is not all that important in chemotherapy-induced nausea and vomiting. Okay, another common side effect is fatigue, and a high proportion of patients receiving anti-cancer therapies, including chemotherapy and immunotherapy and radiotherapy, can develop fatigue. Sometimes radiotherapy, even to just a very small area of the body, will cause fatigue. And we're not absolutely sure how this happens, but one way is that these therapies can result in the production of what are called reactive oxygen species. And those reactive oxygen species may interact with mitochondria in the cells. Mitochondria are responsible for energy production, and if they're not working well because of reactive oxygen species, then that can lead to fatigue. Another mechanism may be by the release of what are called cytokines from immune cells. And the cytokines that are released from immune cells, they're what make you feel bad and tired when you get an infection like a common cold, is because of cytokines being released. And the same cytokines could be released as a result of chemotherapy. So some patients have minimal fatigue, some have a bit that lasts for a few days, but some will have fatigue that lasts for several weeks or longer. Very variable from one person to another. In some patients, the drug dexamethasone, a steroid, can help reduce fatigue, but we try to limit the amount that we use it or the duration because of the side effects that dexamethasone itself can cause. But in some patients, low doses that are tapered off rapidly after treatment may help. Paradoxically, research suggests that the best treatment for fatigue is activity, just being as active as you can be. Because if you rest a lot for a prolonged period of time, then that reduces muscle fitness. Chemotherapy, radiation, immunotherapy, and other therapies can also lead to what's called chemobrain or brain fog, where memory and concentration just are not as good as what they were. And this may be from release of cytokines from immune cells, but also there's some work that in some patients, treatments may actually lead to acceleration of brain aging. Again, this brain fog or chemobrain will get better over time in most patients, but not in all patients. Another side effect that occurs with some chemotherapy drugs, but not others, is hair loss. And this will typically happen in drugs that cause it. The hair may start to fall out about 2 to 4 weeks after the first treatment. And the way that hair is formed is the cells in your scalp are spinning a long monofilament of protein, and that's what the hair is, a long monofilament, sort of like monofilament fishing line. And as the cells produce the protein, it adds to the bottom of the filament to push it up, so it keeps getting longer and longer. But chemotherapy drugs that cause hair loss will temporarily make them not work quite right. So the hair that they're being produced when they're not working right will be thinner than the normal hair, and therefore it'll be more fragile and can break off. So hair is not actually falling out with chemotherapy, but instead it is breaking off. After chemotherapy is stopped, normal hair growth will typically resume several weeks to a few months afterwards. Cooling the scalp during chemotherapy administration can help reduce hair loss by reducing blood flow to the scalp, and therefore by reducing chemotherapy delivery there. However, it works a little bit with some patients, not with others. There can be patchy hair loss, so just some areas of hair will fall out, not others. So some patients do find it helpful to them, others do not. Some chemotherapy drugs will also damage bone marrow cells, reducing the production of white blood cells that are important in infection, platelets that are important to prevent bleeding, and red blood cells that carry oxygen to tissues. And the most important of these is typically reduction in white blood cells. So in all of us, white blood cells protect us from infection. And we all have bacteria constantly leaking into our bloodstream from our intestine, our skin, and other sites. And these are usually just killed off by the white blood cells. But if there are not enough white blood cells, then some may get away and cause very serious or life-threatening infection. And the time when the white blood cell count is lowest, typically with most chemotherapy drugs, is about 1.5 to 2 weeks after the chemotherapy is administered, with recovery of the white blood cells by about 3 weeks. And that's why chemotherapy is often given in 3-week cycles. That's how long it takes for the blood cells, the white blood cells, to go down and then recover to a point that it's safe to again proceed with treatment. The risk of infection varies with different chemotherapy drugs and also depending on just the fitness of the individual patient. But typically about 10% of patients receiving chemotherapy that can cause low white blood cell count will require hospital admission for intravenous antibiotics at some point, with about a 1% risk of fatal infection. So I tell my patients it's very, very important that if they develop chills and fever a week or two after getting chemotherapy, that they go to the emergency room immediately. That if it's during the night, they not wait till morning. If it's a weekend, they not wait till Monday, but go to the emergency room immediately, because it might be a very serious infection that could prove rapidly fatal if the patient does not immediately start antibiotics. So some drugs can reduce the risk of the white blood cell count going down. So one called filgrastim or G-CSSF can do that. And so it does reduce the risk of infections, but has actually a very little impact on the life expectancy of patients with cancer who are receiving chemotherapy. And that may be because, in addition to stimulating the production of the white blood cells called neutrophils that are important against infections, it also increases the production of one's called monocytes. And those monocytes can circulate through the bloodstream and enter the tumor, where they are converted into what are called wound-healing macrophages. And those wound-healing macrophages can actually stimulate tumor growth and protect the tumor cells from killing, and also decrease the ability of the immune cells to kill tumor cells. So some oncologists routinely prescribe filgrastim, and others do not. I personally will not usually prescribe it. Instead, my preference is that if a patient runs into a problem with infection with one cycle of chemotherapy, to just reduce the doses of the chemotherapy with the next cycle, because that's generally a very good way of overcoming most side effects with most drugs. Some drugs can also damage the cells lining the mouth, causing mouth sores, or can damage cells lining the intestine, causing diarrhea. And these are unpleasant side effects that will typically last for a few days to several days or longer. So in addition to being unpleasant, if those cells lining the mouth and the intestine are damaged, those cells are also a barrier to bacteria. So if they're damaged, that also increases the risk of serious infection, of bacteria leaking into the bloodstream. So a patient who has both bad diarrhea and mouth sores and low white blood cell count are at higher risk of developing serious infections than patients who just have low white blood cell counts alone. So there are also many other kinds of toxicity as well that I won't cover in this video. So possible damage to the liver or the kidneys or the heart or any other tissue in the body are possible with some chemotherapy drugs, but not with others. And overall, the risk of major toxicity with chemotherapy is higher in older people than in younger people because they've got less reserve. But we can get around that to a certain extent just by lowering the chemotherapy doses, so that older people will often tolerate chemotherapy if the doses of the chemotherapy are just reduced somewhat. Also, patients with other major illnesses may have reduced ability to tolerate chemotherapy. So that this has to be taken into consideration when giving them therapy. In addition, patients who are very debilitated from the effects of the cancer will be more prone to develop major toxicity than patients who have relatively few symptoms from the cancer. As with so many things in cancer, we are making rapid progress in our ability to control side effects of treatments. So that more and more patients are able to receive therapy at chemotherapy doses that will control their cancer, give them a good quality of life with a low or acceptable level of side effects. On this and other things that may interest you, again, you can get more information through my book, A Short Primer on Why Cancer Still Sucks, available through Amazon Books. Thank you. I hope that this video is helpful to you. Bye.